Hi, everyone, and welcome to OR Today webinars. We have a great presentation for you today featuring expert Victor Lange, Director of Infection Prevention and Healthcare Risk Management, Epidemiology of Alta Hospital Systems. He will explain the infection and cross-contamination risk associated with the use of forced air warming on patients in the OR. You'll learn ways to contribute to improved facility risk review and improved patient warming and infection prevention control protocols, and explore new findings on patient warming. OR Today would like to thank our sponsor, Encompass Group. Encompass is one of the world's leading manufacturers and marketers of healthcare textiles, healthcare apparel, patient warming, and therapeutic support products for the healthcare industry. Encompass believes that every patient, resident, caregiver, and family member should feel safe and comfortable in today's healthcare environment. The way Encompass enhances the healthcare experience is by developing innovative products that are reliably delivered and cost-effective for all providers. The markets they serve include acute care, long-term care, senior care, retail health care apparel, hospitality, and government operations. For more information, please visit encompassgroup.com. For nearly 20 years, OR Today has provided perioperative and SPD professionals with up-to-date news and information about their profession. Our monthly magazine aims to educate readers about new guidelines, techniques, and equipment, as well as practical information for career building, problem solving, and overall well-being. To receive your free subscription to our magazine, please visit ortoday.com/subscribe. Today's webinar is eligible for one continuing education hour by the State of California Board of Registered Nursing. You can obtain your certificate by completing today's post-webinar survey. The survey will be emailed to you 1 hour after the end of today's webinar. We will wrap up today with a live Q&A. You can submit your questions at any time during the webinar by using the questions feature on the webinar dashboard. We'll get through as many questions as time allows. As I mentioned earlier, our presenter is Victor Lange. Victor, you may begin whenever you are ready.
Oh, thank you very much. Appreciate the wonderful introduction, and I thank you all for being here today. Again, my name is Victor Lange, hospital epidemiologist. I'm also background in law. I've been involved in the medical device industry for quite some time, aside from hospital practice. So I've always wanted to know how things work, and that's why I've always dabbled in a lot of research to see how we can improve outcomes in our patient population. So again, I'm very grateful to have the opportunity to speak to you today regarding the topic of forced air contamination risk, especially in the operating room, since it's such a high risk environment. And in particular, this presentation is a follow-up study to a prior publication of mine from 2018, which initially established the correlation of forced air warming devices contributing to an increased contamination risk in the OR. So in terms of learning objectives, it's first of all, it's important to understand the basics as to why we're even discussing forced air warming. So getting a foundation to understand forced air warming itself, and then looking at the cross-contamination factors associated therein. We'll also look at any type of data correlation that exists with forced air warming device components, because as you know, the devices themselves, they're usually comprised of various components, including hoses, attachments, and so on. So just looking at the correlation between the components, airborne contamination in the operating room, as well as seeing whether or not there is any subsequent surgical site infection risk that's potentially attributed to contaminated surfaces or even the air in the OR. And then we'll also review retrospective data, which was the initial data collected in 2018, along with a follow-up surgical site surveillance of those cases that were studied initially in the 2018 population. So the content obviously includes patient warming benefits, obviously making sure that one understands and comprehends the benefits of patient warming or maintaining normothermia, also covering the risk of any type of forced air in such an environment. And then we'll look at the study objectives in this particular research study, as well as the findings and conclusions based on, again, the follow-up study from the 2018 initial trials and the protocol that was published. And then we'll look at we'll cover any type of questions and answers and have a brief discussion at that point in time. So as we all know, there are a lot of benefits to patient warming. First of all, patient warming is intended to maintain perioperative normothermia, which ultimately, we want to reduce temperature-related complications. And ultimately, we see that there are substantial improvements in post-operative results when we do this, when we maintain normothermia or maintain the appropriate body temperature of the patient, ultimately shortening patient stays. Because again, we want to minimize or reduce any likelihood of problems with our patients or any complications resultant of non-maintenance of the patient's appropriate body temperature. So, there's a lot of publication about normothermia and maintaining, normothermia in a patient in countless journals, New England Journal of Medicine, a lot of studies published. And again, we just wanted to kind of dive deeper into this topic to see, why truly the risk may be inherent if we're using an inappropriate way of heating the patient. So the forced air infection risk. Forced air warming devices, among the most commonly used warming devices in ORs, introduce bacteria into the surgical environment, increasing also possible contamination risk of the patient's wounds, or the patient's surgical incision, and it raises the possibility of an attributable surgical site infection. Although some reviews on the subject are inconclusive, a number of studies have focused on surgical surface, like surgery theater or OR surface component contamination, as well as tissue air risk connection. And so this clinical investigation was designed to identify any possible correlation between forced air warming bacteria and consequential surgical site infection risk. So again, trying to correlate whether or not the movement of air in the OR through a forced air warming device or next to a forced air warming device, does it lead to any type of contaminants either on the patient, in the environment, etc. And again, publications have been studied, and there have been a lot of studies that have been written about the disruption of unidirectional airflow, and we've seen actually litigation in the industry for correlation of such. So we look here at a diagram of the airflow itself. So hot airflow from a forced air warming device should not ever disrupt any type of airflow in the OR. And as you know, we have laminar flow that occurs in the operating room and in specific rooms and environments. And if we're incorporating or introducing a different type of mechanism that disrupts such airflow, it can also disrupt the laminar flow, which can thereby negate the reason we have a patient in laminar airflow in the first place. So again, that becomes a problem in itself. So what we wanted to do is we wanted to look at the objectives of why we were conducting a follow-up study. So the primary objective of the study was to demonstrate that even when properly managed, forced air warming units may contribute to greater environmental bacterial load and subsequent infection risk. And that's what we identified back in 2018, that the study that was conducted revealed that forced air warming contamination occurs more than expected in the surgical environment. And the study demonstrated that 42.5% of a sample size of 320 samples were higher than the minimum accepted pathogen levels. And again, that's something that's quite substantial because again, we cannot have any type of contamination in the OR, especially when it comes to the air and the vulnerable patients that are, compromised likely because they're undergoing a surgical procedure, as well as, the patient's been prepped properly in terms of a surgical prep. And so again, we don't want to compromise that. So the way the study occurred, the follow-up study from the 2018 study, is we wanted to see of all those cases where we identified air contaminants or surface contaminants in the room of an OR cases, we did a retrospective chart review, which was conducted on all medical records of patients who had been associated with surgical cases in the 2018 study. And the cases, the procedures were reviewed in accordance with established NHSN definitions of the operative procedure, which included a review of cases for the identification of superficial, incisional, deep incisional, and any type of organ space surgical site event. So in other words, we followed the NHSN definitions as well as criteria for identifying infection. And in this particular case, surgical site monitoring, as we all know, requires, active patient-based and prospective surveillance. And so concurrent and post-discharge surveillance methods were used in this particular study to identify such patients. And this included inpatient operative procedures as well as post-discharge surveillance for any outpatient procedures that had taken place. And we conducted a record review methodology, including not only review of medical records, but we looked at admission reports, readmission, we look at ER records, operating room logs, patient charts in general for any signs and symptoms of surgical site infection. And acceptable documentation included patient-reported signs and symptoms of any type of SSI during the surveillance period, as documented in the medical records by the healthcare provider. And then we also looked further by validating the lab results, any other imaging diagnostic tests, and also we looked at the coded information through the ICD-10 infection diagnosis codes. And for patients in this particular case also who did not have a documented case of infection during hospitalization, if they were inpatient at the time, the surgeon was also contacted by phone to ask if the patient had any type of follow-up post-surgical office visit that had any evidence of a post-operative infection. So in other words, it was a post-discharge surveillance of the patient. And so when we look at the findings from our follow-up study, based on the findings documented in the 2018 study, we see that the primary prevalent pathogens that were isolated were broken down as such. The predominance was Staphylococcus epidermidis, a gram-positive coag-negative cocci, which is an opportunistic pathogen. And we see this with skin contaminants quite frequently. Other pathogens that followed in frequency included a 10% just Staph aureus, 9% Staphylococcus pyogenes, followed by 5% Micrococcus species, 3% each of Corynebacterium and Propionibacterium species. So a lot of these are, common skin contaminants that, again, if they're pulled into an air supply, they can circulate around a room, land on an environment, and they can cause subsequent infection. So again, going over some of the study findings here, what we saw is that based on findings documented in the study from 2018, the primary pathogens, again, were identified on the prior slide. And what we see is that the study did demonstrate that 4 of the 320 specimens collected in the 2018 study demonstrated actually a correlation in surgical site infections in 320 of those cases. 3 of the 4 cases that had surgical site infections included a superficial Staphylococcus epidermidis infection, and then 1 of the cases had the Corynebacterium species superficial also. So this provided, based on the small sample size of 320 cases, an attributable infection rate to forced air warming of 1.3%. So again, this is based on, again, a snapshot. This is not based on, tens of thousands of patients. It's just based on 320 cases that had contaminants present in the operating room. This demonstrated that 1.3% of those actually developed an infection that was attributed to the pathogen that was both identified on or in the forced air warming device or the environment that came from the forced air warming device, and or also inclusive of the patient's wound. We also break it down by the type of surgeries. The table you see here provides a breakdown of the surgical site infections based on surgery type. What we see is 3.4% were OBGYN cases, 5.6% of colon cases. We also see 1.4% of GI cases, and 5.3% of amputation cases developed an SSI. So again, in summary, this does indicate that when the forced air warmer is in use, the risk of for surgical site infection is present, and we could see that statistically. And again, this is just another representation of the classification of the types of surgeries the patients had that were in the study. And what we can see is we could see that laparotomies were identified, 18%, 23%, again, were in this particular case GI cases and so on. So this just is a pie chart that demonstrates what was in the previous slide. So in terms of some of the study conclusions, the forced air warming device component contamination, it is a real risk in the OR. Cross-contamination of the environment is a risk factor. And as hypothesized in the 2018 forced air warming study, we need to look at obviously seeing how we can reduce not only airborne colony forming units, but surface contaminants, because again, the surface contaminants can also include surgical instruments if we're worried about the air and the particles in the air in the OR suite. And so all of this may positively reduce infection risk if we control it somehow. So based on the correlation between pathogen and surgical site infection risk, it has been determined that infection risk may be eliminated through the use of alternate patient warming technologies and techniques. So we need to figure out a way of reducing the air cross-contamination problem in the OR by seeing if there are other ways of warming the patient. And so what's important for this type of study is for, everyone in the facility to be on board in terms of understanding that the problem exists, number one, because sometimes we don't look at the devices such as the air warming units as being a contributing factor to surgical site infections. It's usually, we think of the skin not being prepped properly, or some other cross-contamination factor, but we rarely correlate it with the air warming device itself. So, ongoing vigilance and collaboration is critical. That's why, this particular study, the results were published recently in the Annals of Medicine and Surgery in volume 73 of the January edition of this year. And so we can look at so many different factors when it comes to reducing infection risk. And we look at the OR air quality monitoring, as an ongoing matter that we need to take seriously. We look at HEPA filtration. We look at the forced air warming unit maintenance in itself. Are they maintained properly? Are they disinfected properly? Do you have devices that allow for complete disinfection of the unit? Because, as we know, these units, anything that's used in the OR has to be completely able to be disinfected or disposable, single use. And with the forced air warming units, there are so many components that have various surfaces that you cannot reach adequately to clean. So how does one truly disinfect a surface? How does one truly know that a surface has been decontaminated properly? And so this study did find high volumes of, again, staph epidermidis and also volumes of Staph aureus, Staph pyogenes, Cornicobacterium, Propionibacterium species. Again, a lot of opportunistic pathogens and a lot of pathogens that are normally found in shed skin cells. And so again, if we have the shedding of skin cells floating throughout the room during a surgical procedure, that does pose a risk to our patients, because again, we're concerned about that potential cross-contamination risk, as well as direct seeding of the wound by these pathogens if they happen to be floating around in the air and land into a surgical incision. So even when properly managed, forced air warming device component contamination is a real risk in the operating room. Cross-contamination of the environment is also a risk factor. And so, as hypothesized in the 2018 forced air warming study that was initially conducted, a reduction in surface and airborne colony forming units may positively reduce infection risk. And so based on the correlation between pathogen and surgical site infection risk, it has been determined that infection risk may ultimately be eliminated through the use of alternate patient warming technologies and techniques. And again, this is something that's so interesting to study, is alternate ideas and principles of infection transmission. And this is why we were able to successfully not only hypothesize about what may be leading to infection, but this is what we also found to be an infection source in our operating rooms through the hospitals that I've actually conducted the study in. And so over time, we are studying additional ways of maintaining normothermia, additional ways of warming patients, and we have seen a substantial decrease, even a low percentage decrease of reduction of these infection risks through the use of non-forced air warming technologies in the ORs. So again, I hope that this information may be useful and maybe messages may be taken back to your facilities. And again, it's always important to look at every single variable and every factor that may potentially be eliminated or reduced in order to decrease the infections in our patient population. And so with that being said, I have contact information there. I have my work email address, and then Encompass also has some contact information listed below so that we can answer any questions outside of what's asked in the question and answer session at the moment.
Thank you so much, Victor, for all of this valuable information. As a reminder to our audience, if you have a question for Victor, please use the questions feature on the webinar dashboard. We do have some questions that have come in already. Victor, the first question is, are there specific areas of the forced air warming devices that contain higher concentrations of microorganism contamination or colonization?
Oh yes, that's actually a very good question. As I mentioned before, the forced air warming units, as well as most any devices, they have so many complicated components or parts. In this case, we were identifying pathogens on the hose connections to the machines. We also on the hoses themselves, on the inside of the hoses, as well as improperly maintained, the filters on the devices themselves. So many nooks and crannies are present on a lot of these devices, and all it takes is just the improper processing of any device or any component to lead to such a contamination. And we need something that's able to be disposed of. So even if you have components that are disposable, you need to make sure that the reusable components of the device are processed accordingly. So again, the highest correlation was attributed to hoses, hose connections of the device itself, through which the warm air was blowing, and subsequently blowing through the device and blowing out around the OR suite.
All right, thank you. Our next question is kind of taking off of the first one. Is there any way to ensure that the FAW is completely disinfected both internally and externally?
That again, playing like you said off of the first question, it's very, very difficult to ensure 100% disinfection of virtually any of these devices unless there's a way to send them through a sterilizer. Because again, there are areas of the device that you can't possibly disinfect to the highest potential if they aren't subjected to some sort of gas or some sort of technique in which we either immerse or completely saturate the object with a disinfectant for obviously a specified period of time. So with that being said, it is very difficult to truly say that the device has been disinfected completely unless it obviously undergoes a disinfection process that would ultimately possibly destroy the device itself. So that's why it's so important to have devices that, again, are single use, possibly disposable if there's a way, or ultimately one that doesn't blow any air, because it's that blowing of the air that ultimately disturbs any particular pathogens that may be deposited within the device and dislodges them and propels them into the air. So in summary, it is very difficult to guarantee the complete disinfection of such a device.
All right, our next question is a little bit long, so let me know if you need for me to repeat any part of
Okay.
Based on your study findings, it seems clear that forced air warming provides an inherent risk of microorganism contamination. Have you had the opportunity to evaluate non-SAW technologies, and how would they compare in patient outcomes?
Okay, that's a very good question. I actually have recently been reviewing several products, one of which has been demonstrating to be the lowest risk in terms of cross-contamination, and that is through it's a non-forced air warming device. It's a type of technology that's basically a type of blanket that has heating elements within the blanket that heat up and do not cause any type of air disruption. And the blanket itself is disposable. That so far has been the best type of technology, because again, we look at overall statistically, when we look at data from the CDC, we see a total of at least 14 to 30 million OR procedures performed in inpatient settings, and even if you have an estimated 130 SSIs within inpatient surgeries, we see that so many of them had some sort of forced air warming that took place during that. So that's why we're seeing that forced air warming is such a correlation, along with what I've demonstrated in the studies we've conducted. And of many of these cases, no one has been using any alternate heating technologies other than forced air warming. I've also queried a lot of counterparts in about 60 or 70 hospitals throughout the country, and no one that I've spoken to uses anything other than forced air warming. So again, from what I've studied just recently with these heated blankets that have non-forced air, that may be one of the ways of solving this issue, or at least eliminating that 1% risk or that 2% risk. Because again, 1%, 2%, even if it's a small superficial infection, we want to avoid that at all times, because again, that could be a much more substantial infection that leads to a negative outcome in the patient. So luckily, many of these superficial infections, resolve, but nonetheless, it's something the patient shouldn't have to go through if at all possible. So going back, yes, there are alternatives to forced air warming. Blankets that incorporate non-air movement, just a heating element that's contained within the blanket, has been proven to be advantageous. Excuse me.
Great, thank you. Our next question is maybe a recap of what you have just said, but in case there is anything that comes up that you might want to expand on. This question is, what alternative methods do you suggest for or to help maintain the patient's normothermia?
So again, that is something that I did answer prior, which is the use of alternate technologies such as the blankets with non-forced air warming. There may be some blankets or products out there that actually have a heated fluid that passes through, heated wires, heated chambers, as long as there's not that air, because anytime the air circulates through and passes through holes that are then propelled outside into the environment, that's what we're worried about, is just that air movement, and also ultimate disruption of also the positive or negative air pressures that are in that environment itself. So again, alternate measures include any type of heating element that's contained within the blanket that does not cause air movement.
Our next question is, why has the FDA not issued, or have they, either an alert or recall or a warning about using this type of warming?
That there actually have been alerts, and there have been concerns and also litigation with certain brands on the market. certain brands that do have airflow that cause contamination. So I know that the FDA obviously has priorities. I've worked with the FDA on numerous occasions on various projects, and I know that it's just a matter of demonstrating and providing a burden of proof as to what's truly contributing to infection risk. And I think that this is very underreported, to tell you the truth, because so many people, so many hospitals, so many infection preventionists never really use the forced air warming device in their reporting or in their analysis or in their investigation as being one of the risk factors. You have a patient that has a positive pathogen in their infected wound. Thinking outside the box is rare. And so usually it's attributed to just improper skin preparation of the patient prior to surgical incision, or it's some alternate seating contamination by one of the healthcare workers, the OR tech or the surgeon, or an instrument that wasn't processed properly. But people have not looked beyond that. But once you raise that attention to the topic of forced air warming, and you include that as one of the items that you incorporate in your investigation when you're reviewing a surgical site infection, you will come to the realization that there are many cases that go unnoticed as being attributed to the forced air warming device. So to make a long story short, once the FDA gets enough information from enough from facilities throughout the country or throughout the world that truly they're correlating these devices as increasing infection risk, that's when you'll start seeing recalls. That's when you'll start seeing the topic be much more, I guess, addressed. However, it's a rather premature young topic. I've been able to identify a correlation, and there have been lawsuits that have actually demonstrated and proven that this technology does potentially cause infection, especially with the correlation that's seen in different published studies. So the FDA is aware. The FDA just is awaiting for additional information to pinpoint whether or not this truly has a substantial enough impact. However, I can clearly say that it is underreported, and once the awareness is made, once the CDC also incorporates this as part of a normal investigation into surgical site infections and includes it in awareness through journals, through publications, then we'll see this change in terms of the future of how infections are investigated.
Our next question is, with regards to this study, how exactly procedurally was air contamination measured?
Okay, so we had numerous different devices that we utilized, including we had systems in which air was pulled in through various devices that we have for industrial air sampling. And so what that is it's virtually we have petri dishes or plates that are set up with a sterilized machine that has air that pumps across the petri dish, and any particles that pass through actually go across the dish itself, the plate. And so that's one method. And in that case, those plates are then sent for culture, and we see what grows. So it's done in a sterile manner, but they're set up in numerous locations near a patient, near the device, near the machine, and we were able to capture them that way. So it's an environmental air sampling technique that's widely used to test environmental sources of contamination.
Thank you so much, Victor, for a wonderful presentation and for sharing your study findings with us.
My pleasure.
I would like to encourage everyone to visit today's sponsor to learn more about the products and services they provide to our industry. Please visit encompassgroup.com. A quick reminder to our audience that you can obtain your certificate by completing today's post-webinar survey. The survey will be emailed to you 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 CE hour, and you'll be able to download your certificate immediately once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. We'll be back soon with another webinar. Please visit ortodaywebinars.live for more details and for complimentary registration. Thank you all and have a wonderful afternoon.